A lifetime with autism.
Hello, I'm Norman Swan. Welcome to this programme on helping children with autism spectrum disorder, another satellite broadcast from the Rural Health Education Foundation. Autism spectrum disorder is a term that's being used more and more, sometimes being used appropriately, sometimes not. It includes a group of diagnoses: autistic disorder, high-functioning autism, and pervasive developmental disorder not otherwise specified, and Asperger's. The key with children who are suspected of having autism spectrum disorder is early recognition and diagnosis and prompt intervention. In this programme, we'll also cover the young person who's first diagnosed in his or her teens. As always, there are a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Now let's meet our panel. Natalie Sylov is Head of Child Development Services at the Children's Hospital Westmead. Natalie is a clinician involved with individuals and families affected by developmental disorders. Welcome, Natalie.
Thank you.
Michael Taylor is a full-time general practitioner in Mount Barker, South Australia, and he insists on being called full-time because he's currently medical director of the Adelaide Hills Division of Dental Practice, plus multiple other roles. Welcome, Michael.
Thank you, Norman.
Glad you could tear yourself away for us.
Thank you very much.
John Christie has been a teacher and principal in mainstream independent schools in 3 states, and he's principal of a highly innovative school dealing with children with autism spectrum disorder, and it's called Giant Steps, and it's based in Tasmania. And John is heavily involved in the autism community in Tasmania. Welcome, John.
Thank you, Norman.
Anthony Warren is Director of Young Children and Families with Autism Spectrum Australia. He's a psychologist and a special educator who's worked in various educational, developmental and clinical psychology roles in government and non-government agencies in Tasmania, New South Wales and even the UK. Welcome, Anthony.
Hi, Norman.
Christine Kendall is one of the directors and principal speech pathologists of Spectrum Speech Pathology Services, and you invented that term just to make it hard for me to pronounce it, didn't you? Just to get my articulation moving there. Thanks, Christine. Christine has 20 years of clinical experience in the area of complex communication needs, including working with children with autism spectrum disorders. Welcome to you all, particularly you, Christine. So, Michael, do you see many of these children? I mean, it's probably more common than people think, isn't it?
It is. I mean, I think, you know, in our practice in Mount Barker, a quick review of our sort of records found there's about 15 to 20 of these children with from autistic spectrum through to Asperger's syndrome.
What are the statistics in terms of epidemiology, Natalie?
Well, they're increasing over the years with the increasing recognition and widening of criteria, and the current figures are 1 in 160.
That's common.
That's pretty common.
So Michael's figures would be typical for a general practice then?
It would be, and that's looking only at autism itself. If you looked at the developmental disabilities or developmental disorders, that would be even more common.
So take us through these 3 categories that are within this autism spectrum.
Yeah. So there's the umbrella term is pervasive developmental disorders. So within the pervasive developmental disorders, there are the autism disorders and Rett syndrome and childhood disintegrative disorder. So with the new items for the autism package, they actually are for all children within the pervasive developmental disorders group. In the autism spectrum disorder, there's autistic disorder. There's Asperger's disorder, atypical autism, which is PDD-NOS. Those are referred to as the autism spectrum disorders.
And how different are they?
It's all a continuum, and I think all the children look different at different developmental stages, depending on the amount of communication skills they develop, depending on the intellectual ability, and depending on how severe the restriction is on their interests and their obsessive behaviours.
Anthony, what's the triad that we're dealing with here that gets you within the spectrum? It's communication?
Yes, it's communication, social and repetitive and unusual behaviours. They all share core impairments in terms of social development and communication in particular.
And when you get to the DSM-4, which is what you how you categorise it, the Diagnostic and Statistical Manual, which is not on every GP's desk, thankfully, what are the sort of points that you've got to hit on that DSM-4 to qualify in these disorders?
Well, you'd first consider autistic disorder, and there the child would need to have significant communication impairment, perhaps not much language at all before 3 years of age. the essential difference between autistic disorder and Asperger's is that children with Asperger's have broadly normal early expressive language, although there is a debate. They can still have a delay, but still they would have more functional language than the autistic disordered child. Then the third subgroup that Natalie mentioned, atypical autism, they would still have a very significant...
This is pervasive disorder, not otherwise specified.
PDD-NOS, yes, brackets atypical autism would have that significant social impairment, and then either significant communication or the repetitive and unusual behaviours.
So the main difference between the autistic disorder and Asperger's is that Asperger's must have a normal intellectual ability by definition and must have had early expressive functional language, so phrase speech, by 3 years of age.
And what about the things that go with it? Because when you talk about, say, ADHD, it's very rare to see a child or even an adult who's only got ADHD. They've got some learning problems, they might have conduct disorder. There's lots of things that mess up. It's not a pure diagnosis.
No.
Is it the same with autism, that you get other things bundled in?
I think absolutely. Very few of the developmental disorders occur in isolation. They all are issues that happen to a developmental brain, and so it's more common to have a number of disorders coexisting together.
For example?
So with autism, ADHD is very common. Up to, some studies say 60 to 70% will have significant ADHD.
So ADHD, I mean attentional problems, not completing tasks, fidgety, impulsive behaviour.
Impulsive, difficulty planning, organising themselves, forgetfulness, being distracted, executive function problems.
Yeah. Angela, you wanted to say something?
The Asperger's group pretty well always have what we would call high-level language difficulties, difficulties getting the overall meaning, for example, from text or from a conversation.
Give me an example of that, Christine. What would it sound like if your GP was talking to somebody?
Normally, it may sound very similar to having a conversation with a typical child. What a probe for a GP would be to try and turn the conversation onto their own topic, to move the child away. One of the things I think we do as adults when we're dealing with children is that we feed the children and we let them talk to us, whereas what you'll find with children with Asperger's is that if you try and shift the conversation to something else, that it suddenly gets shifted back again, or they don't pick up the cues that you want to say something to them, etc. So that you're looking for slightly different sorts of issues with someone with Asperger's than if we're talking about an older child than you would with a typically developing child or somebody who didn't have Asperger's syndrome.
Somebody with Asperger's might have very good grammatical structures, good sentences, great vocabulary, even a strong vocabulary compared to a typically developing child, but they have real difficulty having a shared conversation and picking up on the other person's information and then asking a follow-up question or making a relevant comment.
I mean, I had a fascinating experience. I was hosting Late Night Live on Radio National, and I interviewed the music critic for the Washington Post, who's got Asperger's, and was a great friend of Glenn Gould, the pianist, who also had Asperger's. And he is fantastic at a radio interview and can't do a television interview or a face-to-face. How typical is that? That, in a sense, an abstract conversation where they don't have to confront a person is much easier for them. They're good on the phone, but not good face-to-face.
Yeah, very typical, very common. So you can imagine, say, in a classroom in a primary school, working in a year 2 or 3 class, trying to where kids are beginning to work together in pairs or groups, that's actually enormously difficult because they've got to process so much information, emotional and social, as well as spoken information. And then they've got to organise and integrate it and get the overall and then respond. So that's often Asperger's shows up a bit later for that reason.
John Christie, the other interesting thing, I don't want to obsess on this guy, but he had actually taught him self-socialisation skills. He's now about 45, 50, he's actually over 50, by reading an etiquette book.
Yes.
And he learnt it and followed the rules, and that's when he started to emerge into society.
That's right. They learn scripts, which operate in certain situations, but when they're in an unknown situation, it can be really difficult.
So they get out of sort.
The very interesting thing there was he wouldn't be confused by the facial expression. So if it's just radio, it allows him to concentrate on what's being said and what he's hearing. And he's not going to get confused with the facial and the non-verbal. The other things with the comorbidity, Norman, just before we forget, would also be the significant anxiety. that goes with it, and that can be is important because it can be specifically targeted. The obsessive-compulsive behaviours also often co-occur, and so do specific learning difficulties.
And psychosis with Asperger's as well, isn't it? There's a higher incidence of psychosis?
I think that's a bit of a myth, Norman.
Is it?
Yeah, there's not good evidence that there's very significant psychosis associated with Asperger's. I think in terms of autistic disorder, there's also a bit of a myth that most people with autistic disorder have an intellectual disability, whereas we know now that it's probably because more children are getting that diagnosis. It's around closer to 50%. And in fact, many people with autistic disorder have normal or can have normal IQ. It's just that they have marked weaknesses along with some more isolated strengths. It depends a bit on how you conceptualise IQ.
Michael Taylor, just before we get on to our first case study, and I want to get Anthony talking about some of the early indicators here. The cynics say this is the new ADHD, and it's the diagnosis, particularly pervasive developmental disorder, not otherwise specified. This is where aspiring parents find another explanation for school failure and a difficult child that they've just parked in front of the video, just to get the full stereotype of the prejudice here. To what extent do you believe that to be the case, that this is an overdiagnosed condition now that has taken over a bit from ADHD?
I think it's a point that we need to think about and needs to be considered. I mean, there has been an increase in the diagnosis, whether that's because by diagnosis allows people access to services. If you're not diagnosed, you don't get services. That's part of it. But I think the other thing is that probably there was a reluctance in the past of people to actually label someone as, I think your child is autistic. That people don't like,
and therefore children missed out,
and therefore children missed out, and so it's probably a bit of both ways. And if they're getting help, that's good.
And John Christie, the key here is, and you would see this right through the age spectrum, is there are interventions that work, and this is one reason we're having something like this. It's not a pointless exercise diagnosing a child.
Absolutely.
Causes. This is where battle lines have been drawn for years.
That's right. So there isn't a single cause for autism, and there are many pathways to the diagnosis and the clinical triad that makes up autism. So it's a number, it's not just one symptom in an individual that's autism, it's a number of symptoms in the triad that look like autism and that make it look autism. So there are a number of genetic causes or a number of known medical causes that are strongly associated with autism.
Like Fragile X, for example.
Yeah, the genetic ones would be Fragile X, Down syndrome, Smith-Magenis, and a number of others. Also congenital rubella, some neurocutaneous disorders such as tuberous sclerosis, neurofibromatosis, a stronger association with autism. But in the majority, we don't know. We think that there is a strong genetic link, and in fact, each one of the triad, the communication, social, and the obsessive behaviours, each seem to be separately inherited.
And the MMR story is completely dead in the water. It's really fraudulent research that's based on.
I think the MMR there's good research to show that there is absolutely no association.
And what about the leaky gut idea, which was linked to the MMR, the fact that these children have gut abnormalities?
There's been no evidence to support that over the years. I mean, the reason why parents thought that it was MMR, just to go back to the MMR, was because often the symptoms are first noted in the second year of life, and that's at the time when the MMR is also given. So parents tend to remember important events like immunisations or birthdays or Christmases, and so it's related to that. But most of the children who are presenting in that second year, it's noticeable more because they are not, because the deficits in their skills are more noticeable, whereas other children are developing.
And there are various complementary medicines based on these theories. There's gluten-free, casein-free diets and things like that. Any evidence to support them?
No, none whatsoever. So, did you want to go into the theory of that, or?
Well, not particularly. I think what we need to know is just that there's no evidence that they work.
No. There's no evidence that there is a leaky gut at all in autism, and there's certainly no evidence to support the gut-brain theory. The role of the diet is a little more controversial, I guess. There's definitely no definite indication for a casein gluten-free diet in autism, but there also, we can discuss that further, there's no major side effects of the diet, so many parents wish to.
So are many of your parents in your school on it?
Yes, I would say about a quarter of our parents are trying different diets. Anecdotally, they would say that they work, and they'll continue with them, and I don't want to disabuse them of those ideas. There are certainly indications that certain foods can exacerbate autistic symptoms, especially behavioural. So I think it's worth looking at diet, as you do with every child.
I mean, generally a good, healthy, balanced diet is what children need, and we know that children, independent of whether they have autism or not, there may be some foods in diet that they react to. There's no direct association with diet and autism, and I guess the issues that are important to discuss with parents there is more that it's not proven, and our concern for it is that you're introducing...
Don't abandon proven therapies thinking that diet's going to solve all the problems. By all means do it with the other therapies, but not instead of. Take us through the early indicators here before we get to our first case study, Anthony.
Yeah, it's interesting that some research suggests that there are two indicators that are really predictive of a diagnosis at 18 months or 2 years of age, and they are the child not responding to its name, and that this would be the mum or a parent using the child's name, and not bringing things to show the parent, you know, picking up something that they've noticed and bringing to share. But there are lots of other indicators. Now, it's important that if there are a number of indicators, and early childhood health professionals like GPs could use early screeners if they wanted. I think that's quite a good idea.
Where do they get them from?
Well, they could contact Autism Spectrum Australia, and we could let people know what screeners have a good evidence base. But there's a chat in the MChat, and also the ADEC developed in South Australia, Michael, by one of your colleagues. It's a very useful tool. But some of the indicators...
So this is not population screening, this is, you suspect a child may have a problem, there's maybe a quick way to just
I think
really
so,
get
it's a
to
quick way, it adds some provides important information regarding what to actually check when they're observing the child and meeting a very young child.
So what other early indicators?
Well, things like, I've mentioned not responding to name, but not pointing or waving, that's to the parent by 12 months of age, not orienting as you might expect when their name is used, not being interested in other children, not showing interest in what other children are doing, approaching other children, perhaps wanting something they have. It's as though the other child is not even there. In terms of social development, not returning the parent's smile, so not using smiling as a response to excitement and smiling that's initiated by the parent. Parents will often describe that their youngsters seem to be in their own world, and sometimes that their youngsters seem to have a hearing impairment, just was as though they didn't exist. In terms of behaviour, tantrums that don't have an obvious cause, like it's not that someone's taken something away from them, it's hard to work out sometimes exactly why the child's distressed. Unusual interests or attachments, sometimes unusual and repetitive motor movements. In terms of the sensory area, one of the more common reactions would be unusual reactions to distress reactions to noise and to sound. Vacuum cleaners, common domestic appliances. Parents will often say the child's really upset when they turn those on. Those kinds of things.
Let's go to our first case study. Fred's parents bring Fred in to see you, Michael. He's 2.5. He hasn't begun to talk. He didn't babble like other children of his age, they say. He doesn't make eye contact, but he seems to see things around him. And he sits for hours watching his own hands. What are you going to do for young Fred?
This is a worrying story. I mean, I guess in the first instance, I'd like to, obviously expand the history and put some sort of context around it. Is he new to the practice? Are they new to the area? What was the, from the obstetric history through to delivery through to early development? Did he meet early developmental milestones? And so really try to get some sort of wider history and picture, and then also think about the social context. Has he had multiple illnesses in the the first 2.5 years of life. You know, can he hear?
So you think of socialisation or deprivation for another reason?
You know, is he thriving? Has he got malnutrition? So once we do that, and that's really a conversation the GP can do and start investigating, and may even make use of his local network of social work.
So don't jump to the conclusion that this is autism spectrum disorder.
No, and then seek support. And I mean, the support that I'd be looking for initially would be to perhaps refer on to a general paediatrician.
Now, what's a general paediatrician going to do? I mean, they're not usually trained even in Griffiths, and certainly not in the autism, one of the autism tools that are around. So what's a general paediatrician going to do?
Well, I mean, I think it's important that these children get a good general medical assessment, including, looking for differentials, other neurodevelopmental disorders, and, the reality is that, there are important things that we wouldn't want to miss prior to moving down the line of
presumably in a country town, developmental paediatricians are not sort of coming out of your ears.
Developmental paediatricians may, I mean, depending on where you are, it may be 6 months to 12 months before you can access a team.
So is that appropriate referral, do you think?
Yeah, and I think general paediatricians have a good idea of child development and obviously basic child development, doing the
well defended, Dr. Zylog. You can now go back to work and with your head held high.
Now, general child development and understanding child development is a crucial part of paediatrics. And the big thing here is you can't identify atypical development if you don't know typical development. The key thing that the general paediatrician obviously would do is to get that good general family history.
And be sure that you're not missing anything.
Make sure that we're not missing anything. And this certainly is a worrying picture, and I wouldn't be waiting for a formal diagnosis before starting intervention with a child like this. Certainly excluding sensory issues is very important. Doing an adequate hearing test.
So regardless of the diagnosis, you want to get this child on the road?
Regardless of the diagnosis, you want to make sure that the hearing is good, that the vision is good, that there's no neurological regression that we need to pick up, that there are no seizures, and then start the intervention early.
So what's just take it a little bit further down the approach to diagnosis and assessment then, Anthony.
Well, best practice is we've described the 5-stage approach, which Autism Spectrum Australia has developed along with the Royal College of Physicians, and Natalie and I were part of that working party. So yeah, there's the identification of concerns stage, and the key issue there is that we want to, as Natalie's just said, we want to identify the child at risk for a diagnosis and get them into early intervention, not wait for the final diagnosis. The second stage is the medical and the general assessment, and that's the paediatric evaluation. It's a psychological assessment, often speech pathology assessment, sometimes audiological assessment. At the end of that stage, an experienced
occupational therapy, sensory and motor.
Yeah. At the end of that stage, an experienced paediatrician, for example, might go on to give the diagnosis if it's autistic disorder, for example. But if not, then we move to stage 3, which is the autism-specific assessment, and that's about it could be a multidisciplinary assessment team. Certainly there are clinicians trained in good evidence-based tools. ADOS and ADIR, I won't try and explain what they are, but nonetheless highly specialised assessment, including observation of the child in natural settings. This is really important. It
takes a while.
Different seeing a child for 15 or 30 minutes in an office, with in a medical office the child might associate with vaccinations or whatever. You're not going to see typical range of social communicative behaviour necessarily. So, yeah, seeing the child in natural context. And then the 4th and 5th stages are about developing the intervention plan and then monitoring it, monitoring outcomes, but also monitoring for co-occurring or subsequent developmental problems or emotional problems that commonly do develop.
So what that's really identifying is that you don't have to have, the paediatrician doesn't need to know everything. It is very much a multidisciplinary assessment and collaboration, and bringing in each specialist in each developmental area to identify strengths and deficits.
So, Christine, let's assume for a moment, and we're going to come back later to some more detail about how you intervene here, but let's assume that this child does turn out to have is somewhere on the autism spectrum, and communication is clearly a major issue here of delayed language. What are you going to do for a child like this? Well, first of all, what do you find on assessment? What's the core problem? And then how do you help them?
When I look at someone like Fred, Norman, I would be thinking, what does he know about communication? And what you often find, given that we think Fred probably...
Well, he's not going to tell you very much.
No, he's not. So I'm going to need to observe that and see. His parents are going to be able to tell me, and I'm going to do a range of things with the child to try and determine what it is that he knows. So I'm going to have a look at his understanding of language. I'm going to have a look to determine whether he understands a range of words, whether he needs extra cues for that, whether he follows and understands non-verbal communication such as gestures, pointing, eye contact, etc. I'm going to have a look and see, even though he's not talking, does he get his message across in another way? Does he actually attempt to get messages across, or is it up to his parents to be interpreting what's going on there? So there's a range of things that I'd be looking at there, and then depending on what it was that I found, and with Fred, as we think he is autistic, he probably has a number of issues along those lines. So I would be working with the parents to teach them how to interact with him, how to engage him. He probably doesn't have very good play skills, so I would be looking at those, teaching
Give me some
those.
of your tricks. What sort of things do you do?
If I was wanting to teach him to ask for something, and probably Fred's not doing that, I would be sabotaging.
So he doesn't recognise that when he needs something, he's actually got to ask
do
a
something.
parent for it.
That's right. That's right. If he wants a
Either
drink, he's
verbally or
probably
non-verbally.
standing in front of the fridge, regardless of whether there's anybody there. So if Mum's down the back hanging the clothes on the line, Fred's still standing in front of the fridge, waiting for the drink to appear. So the type of thing that I would be doing is teaching him that when he wants his drink, he has to give Mum his cup, for example, and he needs to go and find her to do that, which he won't be able to do initially. And it's helping, it's working with the parents so that they know how to do that, so that that can happen a lot of times during the day. Because one of the things that we know about working with children with autism is that they don't generalise readily, and they need
So you've got to
lots of
teach them
practice.
individual circumstances.
A
high degree of specificity to the task.
What you need to be doing when you're first starting working with the children is using things that they're interested in.
But and reteaching in each context.
Yes, and then that's right. So you'd start off with a couple of things and then gradually expand that.
And how many hours a week does that involve?
The more opportunity for practice, the better.
Which means the
is
parents
why
have
you
got to
need to be
become
working
therapists.
with the parents, exactly, so that they understand and know how it is they can do those things.
So, Natalie, just very briefly, what we haven't covered here are the specific repetitive behaviours and the sort of savant capacity. Just 2 minutes on that and what you see here.
Those are two separate things, the savant and the repetitive
understand.
behaviours. So the repetitive self-stimulatory behaviours may be typically the child who turn over the Thomas the Tank Engine or the car and spin the wheels rather than play functionally with that toy, or a child who would line up the objects and become fixated on the line and the grouping rather than actually playing interactively and wanting to engage in it. There may be other little rituals during the day that they do, that they get stuck on rituals. Whereas the savant is about a very small percentage of individuals with autism have these savant skills where they have an incredible strength in one specific isolated skill that is very discrepant to their other intellectual developmental areas.
One approach we would take with repetitive behaviours is to see them as an opportunity
To teach.
to teach, to perhaps to shape, to move to more appropriate play with, say, Thomas.
So you kind of
So that
grab
would
that
be-
opportunity and change and create
Yeah,
change.
the old way used to be to try and extinguish those behaviours and even use punishment. I'm talking about a decade or longer ago, thank goodness. But they're rather now, we would view them as tremendous opportunities to base some structured learning program on.
And the chances are that a child like this has a high risk of being intellectually delayed.
Yeah, I think Fred sounds as though he's at high risk to have an intellectual disability.
It's difficult to predict that at this age, but there's a difference between the obsessive interest and the repetitive behaviour. So Thomas may be obsessive, and then you can use Thomas to teach play skills. You can teach Thomas to teach facial expressions. You can use Thomas to teach colour. That was Anthony's, using the interest in Thomas to be able to teach a skill. And the repetitive behaviours would be the different other things like the lining up or the stacking or repetitively running around.
So you're using the child's interest to engage them,
and
to be able to work with them.
And when you do that work, which is teaching them, conditioning them in many ways to go to the parents, do the verbal skills speed up? Do they actually start articulating as well? Do the words start coming as well?
With Fred, probably not immediately, but certainly down the track. I mean, one of the things that you have to do when you're working with a child like Fred or a child who is autistic is that you're working on a number of different areas at any one time. And one of the things that you're looking to do is to teach communication for now whilst you're anticipating what's coming.
And it sounds, given that we're talking about repetitive behaviours, we're talking about just reminding ourselves of the triad, socialisation problems and communication issues, it sounds as if the sort of treatment you're giving helps both communication and socialisation.
Certainly, because communication is about socialisation.
Absolutely. So one of the key intervention strategies is to follow the child's lead and imitate what activity or the thing the child's doing. And what you're doing is you're matching simple language with the actions, and that strengthens the idea you're getting at, that you're actually improving the child's chances of becoming verbal earlier.
Let's go on to another case study. Sam is an 8-year-old boy. He was doing well in the first few years of school, but now seems to be struggling with his schoolwork. He comes to see you. They're new to town. Michael, his behaviour is changing too. He seems to be fighting kids in the playground, and he loses his temper throughout the school day. And the school's getting a bit upset with this as well, and the parents have brought him along to see you.
I guess the first thing I'd wonder about was whether he really was doing well at school in the first 2 years. I think that story, I've heard it, on a few occasions where parents bring their child in, sort of second year, third year at school, and say, we've discovered that he's having these problems, he's not socialising well with other children, and when you look back on reflection, they may have been in a large open plan type school and really may not have been doing all that well in reception 1-2. So if it was truly a child who was 8, who had been doing well until then, you'd be wanting to take a much more thorough history. Well, you're just going to say good history anyway, but you'd be looking for other possibilities, like, has there been major events in the home? Have there been, is there, issues that, of divorce, of separation, have they lost a grandparent? So you'd be looking at those sort of issues.
Things that create a troubled child.
Create a troubled child that is really, sort of...
But it could be a child with generalised anxiety disorder or social anxiety disorder, which is hopelessly underdiagnosed.
Yeah, that's true. The giveaway, though, in terms of the differential diagnosis is the information you get from the very early history. So, anxiety might be more obvious a little bit later on, particularly after school entry. But the child with autism would have signs and symptoms from very early on, from birth actually, but we're not... So
this is not what it turns out is, although it sounds like a falling off trajectory, in fact it's a fairly steady trajectory, and it just happens that it's come to a head now.
Yes, that's right. Yeah. Perhaps because it's a bit more sophisticated social environment at school, the learning demands are a little more complicated, that the child's not managing very well.
But it may also have been a child with high functioning autism who's had reasonably good skills and good languages and has had things in place, but with the increased demands in year 3 has become more anxious and therefore
So, we know that kids on the spectrum, high functioning kids, are good at things like they have good strong memories often, so they're good at rote learning, so they remember the more factual things, and that's what the first year or 2 at school's about. Maybe good word recognition because they've got good visual skills. It's, as Natalie says, it becomes a bit more...
Christine, you were going to say something?
I was just going to say, Norman, that one of the things that we didn't mention with Fred, but which holds true for someone like Sam, is the fact that these children respond extremely well to visual cues, and you use a lot of visual systems with the children. And if you think about prep grade 1, grade 2, in a classroom, there's a lot of visual support to the the curriculum, and once you're moving grade 2, grade 3, that starts to fade away. It's much more language based, and so that the children are having to rely much more heavily on their language skills, and it's often when you start to see the fall away in skills, because the expectations are just so much greater for them, added to which the social level of the rest of the class also starts to increase, and that's often when that
the disparity
difficulty,
becomes wider.
yes, with their social skills starts to show through.
That's also where the actual having the diagnosis gives you the understanding and allows the teachers to know what the appropriate supports and scaffolding in the classroom are.
That's right, because one of the things that happens that you see, and John, you would see this a lot, that happens at this stage is the children start to be called naughty, and they're managed in that way rather than an understanding of the difficulties that they've got.
But what I'm hearing, correct me if I'm wrong, what I'm hearing from all of you is that in fact, regardless of the diagnostic label within the Diagnostic and Statistical Manual, what you're all identifying are weaknesses and strengths within an individual child which merit targeting in their own right.
Yes.
And regardless of the bundle that it comes in, whether it's Asperger's or high-functioning autism or autism itself, that's what you're looking at.
Yes.
Exactly, although the child on the spectrum will need a lot more structure and more I guess, supports. And it's important to actually help the child understand what he's not managing, because they don't have that same level of insight as another child with, say, a run-of-the-mill learning disability might quite quickly get some ideas about, well, how to cope socially in the playground, how to join in, for example, or how to have a conversation.
They're not picking up the social cues.
Yeah.
I think that is important to try and identify the diagnosis and to have that thorough, as much a comprehensive assessment as possible. But the actual, because it's a continuum, it's not crucial. The intervention is what is crucial.
So and what I'm hearing also is that let's assume that this child is on the autism spectrum and it's going to be diagnosed because there's been a continuum of problems and they fit into the categories. What are the areas of intervention? Anthony, take us through what are the available therapies here that have proof behind them, that have scientific evidence behind them.
Yeah, in terms of Sam, the 8-year-old in primary school, you'd be wanting to look at playground interventions. So that would be a combination. We know that socio-educational approaches are helpful generally for kids in schools.
What does
that mean? That means role-play scenarios in classes with, in pairs and small groups, then an opportunity perhaps to practice out in the playground with some supervision by the school guidance officer or special ed teacher to really work on the specific skills that you're targeting. We know that classroom and educational modifications help enormously. So that's adjusting the task in the classroom, it's maybe using visual supports, it's maybe setting out the task in a much more structured way. We know that visual supports generally are very helpful for kids on the spectrum, and we know that routine and structure that Christine's mentioned helps too. So it's those kinds of things, interventions in playground settings, that's very important, because Sam's going to soon be bullied and teased because he stands out as being different, and as kids with Asperger's say to me, other kids don't like kids who are different.
Yeah. John, what happens at your school?
Well, my school specialises with children who are very severe, so I don't meet the Sams of the world.
So you meet the Freds of this world?
The Freds of this world? No, I don't meet the Freds of this world yet. If Fred starts to present with severe challenging behaviours at school, he may come to Giant Steps. However, what Anthony is saying still holds true for us. We would want to put in all the supports that are necessary for any child, and it may vary from one child to another. In a normal classroom, as Anthony was intimating, you would want to work with the whole class group. And one of the difficulties we often have is that parents want to keep secret that their child is different. So teachers are often not allowed to talk about Sam's or Fred's differences and needs to the other group. And yet the peers can be the most productive source of help. Apart from working with the class group, you'd want to work individually with, is it Sam? As well, because he needs to learn skills like, how do I get into a game that's already operating in the playground? What are the steps that I have to go through to become part of that game?
Learn the rules.
Learn the rules. And he won't know that. He won't be able to anticipate those or work them out for himself.
Because he can't watch the group to learn from them.
Exactly. He'll need to be taught step by step.
Or he'll learn the rules in a very inflexible way, and
They'll work one way but not in another situation.
That's right. So it's important to teach variation to rules.
So these children, let's go back to Fred. So he's showing quite major problems at the age of 2. What's Fred going to be like at 8? Let's assume he's got mild intellectual disability. What's he going to be like at 8, at the age that Sam's at?
Well, he could have done quite well. It really depends on his inherent intellectual abilities and the significance of his communication delay, the extent of that. We know at 2 or 2.5 he had very little language, so we might assume that he's got very significant communication impairments. What Autism Spectrum Australia would suggest to the parents is obviously early intervention, but then perhaps moving into one of our schools, similar to John's school, and then we would transition on into a satellite class. Which
But
is
what if you're living in a small country town a long way away?
Well, then he's probably going to go into a mainstream kindergarten class. If he's very fortunate, or if he has that higher level support need, he may be able to access a class for mildly to moderately intellectually disabled children, but they are few and far between. So
and in most states they'll get a teacher's aid in or something like that.
That's exactly right. In the mainstream he'd get some specialist input and some maybe.
And that's
some
where that structure
support
that you're talking about, John,
Yes,
comes
exactly.
in.
But speech pathology would be obviously a critical intervention, and that would be delivered not just at home but very importantly with the school.
And can you still be delivering that at 8?
Most definitely, yes.
So you're
Yes.
constant catch up here and keeping them
Yes,
progressing
and what you'd also
developmentally.
be looking at this point, Norman, is the literacy development as well. It's perhaps, if we're looking at a mild to moderate intellectual disability, I would anticipate that Fred might learn to read.
I think that's you touched on a very important point,
read.
that people with autism, children, young people, continue to learn and make progress, steady progress. And that's important. They continue to have access to that expertise. We've seen young adults who weren't verbal who went on to acquire some speech, very limited, but nonetheless. And so it's a matter of matching the techniques with the child's or young person's needs.
So what I'm hearing is that for each area of deficit, to use a pejorative term, there are proven therapies, and I assume you beware somebody who thinks they've got a simple answer for it all. This is I mean, it's a hackneyed term, but this is a multidisciplinary approach and multifaceted to get it working.
Yeah.
The main thing is when they're little is to give them that, so they go from object focused to person focused, and then give them a communication system. So whether that communication system is visual, with verbal, maybe with signs, whatever works with them. And it's been shown that whatever communication you give will stimulate expressive language. So a lot of parents are afraid if you teach to sign or use pictures, the child won't talk, which is not the case. It will all stimulate language.
Right.
And then as the language develops in primary school, so at 8, they develop higher order language, where you need to learn sarcasm, metaphors, social use of language. It's the
So but what we're describing here is broad-based, multifaceted.
That's right.
And
lifelong
There's always
support
things
that's
to do.
appropriate to the individual and progress continues.
And you think you can get that in a country town?
Look, I think it's limited and patchy actually wherever you are, but often more so in regional areas. There are some new tools, some new possibilities. Services are expanding.
I also think though that
I think that's variable, Norman. I mean, I know some country towns where you get wonderful paediatric services. Towns of 1,200 people who have visiting psychiatrists, speech therapists, psychologists, who have really made an effort to, provide a comprehensive service. To me, what you're describing is almost the danger of don't let these children see one therapist. This is an ideal role for a GP as a generalist, as the feedback loop. How are things going 12 months down the line, 2 years later, 3 years,
With the
4 years
psychologist,
later,
with the paediatrician, with the
speech
pathologist.
pathologist, with the team. This is true.
I think that's a very important stage 5 of our assessment model, the monitoring of outcomes, keeping a really close eye on which therapies are they matching, as Natalie's pointed out, the ever-changing developmental presentation of the young person.
And I think it's the same for all the therapists and professionals involved with the children, that we're all aware that one person isn't going to meet all their needs, and that it may be that they don't see it.
Well,
a range of people that we're all referring across.
We've got a question here for you, Natalie, which is what medications, if any, are useful with children on the spectrum?
Okay. So there isn't a particular medication that targets the core symptoms of autism, but as we mentioned, the comorbidities, there are 4 major areas where medication can be very helpful. And the one is the anxiety and obsessive compulsive. As soon as the anxiety impacts on the individual's ability to learn and make progress, we need to look at the role of medication. The same goes for the attention.
So what, SSRIs? Or?
The SSRIs would be primarily of use, and usually mainly after a child is 6. We wouldn't probably think of it under that. The ADHD is very common in some studies, up to 70% of children.
So what stimulants do work?
Stimulants work very well. But obviously with all those medications, if there's associated intellectual disability, there's a higher risk of side effects, and idiosyncratic responses are more significant. So you do need to start with all the medications very low. The other area is the sleep disorders. So to help the child get into a good sleep pattern, medication can be very helpful there. And then the aggressive behaviours, the challenging behaviours.
Another question from rural Victoria for you, John, which is the extent to which, just give us a sense, the person wants to have a sense of which children are suitable for mainstream schools versus special schools such as yours.
For a child to be in a mainstream school, they would need to have skills such as being able to cope with noise, extra noise, changeable environments. They should be able to copy other children. I would be worried about a child who is bothered by light, by changes of routine, and I think a normal primary classroom would be the very last place in the world they should be. So
can they progress to a mainstream school?
Yes, I think with some time in a sheltered environment, such as a special school, they can certainly move on. As with maturity and with skills training, they can certainly move into a mainstream.
You're looking less certain, Anthony.
Aspect's educational model is essentially a transitional one. So children might move into our base school, which is a special school, but the majority of them would move on into a satellite class program. And over the course of their school life, 80% of children would transition from our school to more inclusive settings. Not necessarily all into mainstream settings, and many of those who do move into mainstream settings need ongoing support, obviously. But I think having a transition focus is very important to provide many more opportunities for people to become part of the community.
Let's go to Diana's story. Diana's age 13, she's in year 8, the local high school. She's struggling academically, mildly disrupted in the classroom, and she's seen as a challenge. And although she interacts reasonably well with the other kids, she's reluctant to join in most activities, and she's seen as a loner. She's a bit underweight and has low self-esteem, and her parents wonder whether or not she's developing anorexia nervosa or something like that. And again, another one you've not seen before, another child you've not seen before. Michael?
Yeah, I mean, this is a difficult story, and
that's why we've put it in, just
thanks,
for you,
yeah,
Michael.
thanks,
because you're a full-time general practitioner.
That's the one, yes. And the full-time general practitioner would be thinking, one, I'll get some more history, and whilst getting some more history, I'll be trying to work out who is the appropriate person to get some help and assistance to not only establish a diagnosis, because I think a diagnosis is important.
Because this could be a depressed child.
She could be depressed. She could. There could be a variety of issues, and so I would be considering a referral to local mental health workers. I may be considering a psychological assessment. I may be considering a general paediatrician review, really depending on what the context of this. So it's not a story that I'd try to do in one visit. I would be looking at probably doing some initial screening type medications and getting them back for a longer chat and making sure that the parents are there as well, and I give a chance to engage them. I learned one story once, Norman. I got a lovely story from a teenager once, and I was absolutely convinced that I knew exactly what was right. And she came back a week later with her mum and said, I told her to get over that. And that was it. Child was fine.
Just get a hold of yourself.
Get a hold of yourself.
I mean, being a girl, autism spectrum disorder is a little less likely, isn't it? Because it's sort of a quarter of the incidence of boys.
It's one girl to every 4 boys, but it's still certainly...
So what questions should the GP be asking here to make you suspect that this could be on the spectrum rather than a depressed child or a child who's...
I think the issue is not to try and make a spot diagnosis, but to go through this in a very systematic, organised way. And you can't always do that in a 10-minute consultation, so it certainly would have to be staged. A good psychosocial history is most important, particularly at this age. Struggling academically, I'd certainly get the school counsellor to re-look at her intellectual abilities, look at the specific learning issues, re-look at what her language is like, if we've maybe missed a language disorder, look at her other skills-based. And once we've done that, then start looking at communication, socialisation, and her behaviours and interests. And definitely look at the possibility of an attention deficit disorder. An inattentive ADHD could look the same. A child who was depressed, a child who was starting to,
But equally they could coexist. Even an eating disorder could coexist.
Absolutely. And that's why unless you actually look at each area very specifically and in a structured, organised way, we're going to miss things in this child. And often there's going to be more than one thing happening for her.
So, Christine, it's back to basics again. It's looking at the communication, the socialisation and repetitive behaviours or curious obsessions. If this child did have, say, Asperger's or high-functioning autism, what would be the flavour of the communication as the GP talks to this young girl?
Again, similar to what I described earlier on, they're going to be struggling with conversation. They're going to be fairly
Mind you,
literal.
most adolescents do.
That's the challenge when you're looking at adolescence, is it just that I really don't want to talk to you, or do we have a problem here? And that's where taking it, perhaps getting reports back from schools, there are checklists and things that you can be giving to teachers, to parents to have a look at those sorts of issues, those communication issues, that will give you more information than you might just get
But wouldn't it often, without a formal assessment, because many of these children can actually talk quite well, their expressive language...
They're quite literal too, though, when you're talking to them. They're quite concrete to talk to, and you start to pick that up. And again, it's what Natalie said before.
Just give I think we kind of know what you're talking about here, but so it's a very... Just give us a flavour of concrete communication. What is it like?
I asked an adolescent today, they're going to McDonald's, and I said, so do you like soft drinks? He said, no, I like hard drinks. Or I said to him, and what is your new teacher like? And he said, well, she's a woman, she's about 40, she wears these clothes. Whereas another adolescent would immediately understand what I mean.
She's a bitch.
That's right.
So, yes, that's sort of like shake a leg, and they literally
it's mechanical, in a sense, or mechanism.
Very literal.
Very literal.
So tell me what Fred might be like at 13. This is the 2-year-old who had really quite significant communications delay. Give me a flavour of what Fred's like at 13, if he's had reasonably good interventions.
Well, it's possible that he would be in a support class in a mainstream high school, at least receiving, if he's in the mainstream, he'd still probably need quite a lot of support, but the intervention would have made the difference between him perhaps being and staying in a special school through his career. He'd be much more social than he might otherwise have been. He'd be much more communicative. He'd need a lot of support around learning tasks in the classroom, but he'd be able to manage adapted tasks.
And what do you think about his communication skills?
They'll be limited, Norman. He probably will be talking, and but it will be limited. He'll probably be able to have a reasonable conversation with you, but again, limited around the things that are here and now. He might be able to answer questions for you, but again, limited.
What about Sam then, the 8-year-old who
If I just come back to Fred, one thing that might have worked well for him was if he had good intervention, people picked up on particular strengths or talents and capitalised on those, his self-esteem might be relatively intact. And it might have meant that also he had some social status amongst his peers because he was good at some things. That sort of...
So it's not so much just to pick you up on the self-esteem thing, it's more self-efficacy than self-esteem though. He can achieve, he knows he can achieve something.
Yeah, he knows he can, and he feels good about himself though. He might have some, by social status I mean that other kids...
You're scaring me here. You don't believe in improving a child's self-esteem just for the sake of it, do you?
No, not at all.
But what you're saying is identify strengths.
I'm saying that he has a positive identity
if
he's been managed well and had good quality intervention at the end of all of this.
In other words, taught to achieve. And the 8-year-old Sam that we saw earlier, what's he going to be like at 13? Can they fall away, or they just continue on that kind of trajectory where you just keep them developmentally on track? What's the story here with Sam?
He'll probably be talking in sentences but having difficulty with comprehension. So many, they can talk very well but not understand as well, and so teachers think, well, he's talking so he should understand, but that's not actually the case. The comprehension lags behind, and often they have difficulty with the context in which they're talking about something. So if they read a word tear, they might have difficulty comprehending the word tear in relation to that line, and in relation to the paragraph, and in relation to the whole story. So they'll be focused on the detail, but not see it in the context of the story or the social thing.
Yeah, I think there's a big risk Sam's learning difficulties will have escalated if he hasn't had good support and understanding, and that socially he would have gone downhill as well. If he hasn't...
What interventions at school level are available for teenagers then, these young teenagers, John?
Schools have a lot of work to do in many cases because the average high school is not necessarily appropriate for them. If they put some structure in the child's day, that they make sure he has a comprehensive timetable that reassures him what's going to happen, that he has a mentor that he can relate to when he needs some help, that he has a retreat that he can go to when he's stressed, perhaps the library or something like that. Often if they can find a high-status student to take him under his wing, a buddy, that can help too.
Tell me about this new Medicare item, Michael.
As of February this year, there's now an item number which allows a GP, on referral by a GP to a psychiatrist or to a paediatrician, a specific item number for autism. So on the referral, a GP refers a patient who they suspect having autism to the paediatrician. The paediatrician can then collaborate with other members of the team, be psychologists and allied health, and they can formulate a diagnosis and formulate a detailed plan. So there's a specific item number for that. The essences are that a paediatrician can ask for up to 4 visits by a psychologist, speech therapist, occupational therapist in the formulation, and then on completion of the plan, activation of the item numbers, that family can then access another 20 services. So it's pretty good. It's an improved access for the children.
And it's a variation on the enhanced patient care item, but more specific to autism spectrum disorder.
Yep.
And just finally, before we go, only a minute or two left, when we were talking about preparing this program, you told me about a fascinating sort of story, perhaps quite troubling story, of late presentation, maybe 16, 17 years old. Just give me, because I suspect a lot of GPs will have seen this and not necessarily recognised it for what it is.
I think we're talking, often the higher functioning, more able children can go unrecognised. Very often the gifted children, who are very, very talented, may go unrecognised as being slightly unusual, and they may have specific interests be low.